Dear Chairman, ladies and gentlemen, it's my great pleasure to be here representing Poland, representing EAPCI, during this joint session in which I will be talking about optimizing PCI outcomes with intravascular imaging that indeed allows us for more personalized, case-based approach to the percutaneous coronary angioplasty. There are several features that we have to look at while doing PCI that can be visualized using intravascular imaging, and both IVUS and OCT-based studies have shown that PCI guidance with intravascular imaging can improve clinical outcomes, including majority also of hard clinical endpoints, such as cardiac death and all-cause death. This data translated in the upgrade of the societal guidelines recommendations for intravascular imaging guided PCI. For instance, the European Society of Cardiology guidelines now recommend with the highest class using IVUS or OCT for PCI on anatomically complex lesions, in particular left main stenosis, true bifurcations, long lesions. 1 year earlier in ACS, the intravascular imaging guidance for PCI has been already recommended with the prior iteration of the guidelines. Very recently, just 6 days ago, very interesting data were published by the investigators of the OCCUPY study that showed that we should be particularly careful when doing PCI on long lesions and small vessel diseases, in small vessels, as these features were identified as the predictors of PCI suboptimization, and at the same time they are our bread and butter of daily cath lab practice, so I think it's an important piece of information to bear in mind. Speaking of optimizing PCI outcomes with IVUS and OCT, we naturally want to have our edges of the stents in the healthy segment. We want to land with the stent within the area with plaque burden below 50%. We look at the malapposition, especially at the malapposition length. We want to have our stent expanded and achieve the MSA index to average reference lumen at least 80%, optimally 90%. But all these features we are looking at after stent placement to the coronary artery, whereas it's super crucial to perform intravascular imaging already upfront to both prepare for the angioplasty, to have a good sizing of our stent, and also to look at the plaque morphology, as nowadays having available several dedicated devices for plaque preparation, it has true clinical implications. Just to briefly remind, while we are sizing by IVUS, we go usually from media to media as presented here on this picture, and then run down to the nearest stent available. If media is not visible, we can also size based on the lumen to lumen measurements. When we are using OCT, we check the external elastic lamina to external elastic lamina diameter as presented on this picture, and then round it down to the nearest stent diameter available. So in practice, in this case, we look at the distal reference, we check external elastic lamina measurements, EL to EL is 3.8, lumen diameters is 3.37, so for this case, the stent 3.5 would be most likely optimal. But having all these devices to prepare plaque before placing the stent, it's super important to check the plaque morphology, and that's particularly the case for calcified lesions. We look at the circumferential, how much of the vessel circumference is affected by the calcified plaque. We check the arc, we look whether there are present any calcified nodules. All these features have been summarized into available scores of the risk of stent under expansion, but I believe for daily practice it's important to remember this rule of 5, stating that if the calcium thickness is 0.5 millimeter with length of at least 5 millimeters and at least 50% of vessel circumference is affected by the calcified plaque, it means that NC balloon will most likely not be enough, and we should proceed with additional lesion preparation, calcium modification, whether it will be, for example, rotational atherectomy, as presented in this case, which it allows to nicely increase the area with rotablation. For circumferential calcification, very easily detectable using OCT, as you can see in the right hand pictures. With circumferential and superficiality, we can be successful frequently with just cutting and scoring balloons. Also, intravascular lithotripsy can be used in this scenario. Whereas for the deep calcium, intravascular lithotripsy appears at present the method of choice, like in case of this 67-year-old gentleman who presented with angina class 3 with significant lesion in proximal LAD. His calcium angle was not that much impressive, nevertheless the calcium thickness was problematic, definitely. He had a very large calcium thickness. Looking more precisely at different cross-section at the site of MLA, we see that there is a morphology of calcified nodule. Having all this information, I decided to go with intravascular lithotripsy with balloon of 3.0 per 12 millimeters, and having performed the sizing using OCT, we then proceeded with DES implantation 3.0 per 36 and post-dilated with NC balloon 3 and 375 based on OCT measurements. You can see here the corresponding cross-section, and also here the corresponding cross-section of this calcified nodule, how it changed after application of intravascular lithotripsy and then after DES implantation with subsequent post-dilatation at the distal site, at the proximal reference site, and at the site of MLA. This is the final, I think, acceptable effect of this angioplasty with good expansion confirmed also by optical coherence tomography. Can we do it only based on angiography? Naturally it is doable, but we have to realize the fact that we are not serving best to our patient, and that we have available both imaging and devices, modalities that can help us improve the long-term outcomes of PCI. For me, particularly convincing is the fact that just looking only at the angiography, we will miss 1 out of 4 substantial calcified plaques. Substantial, I mean those who have at least 50% of vessel circumference, that would be easily and clearly visible either on IVUS or on optical coherence tomography. But imaging is not only calcium, we can also very elegantly visualize mixed lipidic plaque, as we can see here in the mid segment of RCA. That is accompanied by the almost circumferential calcified plaque with a degree of calcium above 270. The calculated length was around 50 millimeters, distal reference 3.75, proximal 4.25. Again, here we see the mixed lipidic plaque at the snapshot, and here arrives the calcified plaque with well-delineated borders, which is affecting actually more than 270 degrees of vessel circumference. In this case, I also proceeded with intravascular lithotripsy for the for the proximal segment, and that allowed to proceed with 2 DES stent implantation with the following acceptable angiographic effect and expansion of around 80%. Equally good in guiding PCI is IVUS, which will also allow us to select the length of a stent, in particular when we use the motorized pullback, decide on landing zones, define the plaque type and the vessel size. Here are the examples of calcified plaques, and the very important feature of calcification visible on IVUS are reverberations that will also change the pattern and increase the intensity after adequate rotational atherectomy, being indicative of adequate lesion preparation. Which is better, OCT or IVUS? We sometimes are asked such a question, and I think this study elegantly addressed this question, showing that high definition IVUS is equally precise as OCT in identification of calcified plaque, as well as in confirmation of adequate plaque preparation. But both high definition and the standard version of IVUS will allow us to confirm the landing zones, whether we cover completely our lesion, where our struts are opposed, and most impactfully whether we have our stent well or not well expanded. Just using a standard 20 megahertz IVUS while doing this PCI on the left main just before arriving here to this conference, I realized again how crucial it is to have IVUS in the left main PCI. I think this is it goes without saying that this is the current standard and it's a must to have it just for the PCI deferral. If the MLA is more than 6 square millimeters, we can more safely defer the lesion, but naturally always for the PCI guidance. And here, after post-dilatation, stent implantation 3.5 per 80 millimeters with the intention to further overexpand this well-expanding stents, and additional post-dilatation including proximal optimization technique, we performed the IVUS, and which was supposed to be the final IVUS for this patient, but we immediately realized that the very proximal edge of my stent at the proximal side was not touched by the pot, by the balloon during pot technique. So I did repot to have again to achieve adequate expansion of the whole stent in the left main, including the most proximal edge here. So indeed, this expansion is something that really matters, and we do want to prevent such a situation like in this picture, where the vessel diameter is, for example, 4.7 and the stent diameter is 1.7. This is very tough to correct. We can, it's such a scenario, proceed with some intra-stent use of IVL as off-label use. This is a bailout option, but definitely this is something that we need to be careful about. And if so that's the
yeah, if we can have a slide back, and if you can go to the maybe conclusion.
Yes, just because it's already. So to conclude, because I think the stent failure is it's a clear indication for the use of intravascular imaging. Intravascular imaging allows us for MSA improvement, resulting in reduction of hard clinical endpoints. Its benefit is clear and even higher when we use it pre-PCI for PCI planning, not only after stent implantation. And we should use it for complex lesion just always, in particular for left main, bifurcation, long stenosis, and small vessels. And if in the management of stent failure, intravascular imaging is actually a must. And let me also take this opportunity to invite you to the EAPCI summit that will take place in Munich, 19 to 20 February, and will be a great occasion to see the best practices and very interesting cases and science, with some travel grants being planned to be awarded for those who were selected to presentation. Thank you for your attention.